Hello, all. We're going to give it a few minutes as people begin to populate the session. Good afternoon. Thank you all for joining. We'll start promptly at 1 o'clock Eastern Standard Time. Good afternoon, everyone. And thank you for joining the discussion session for the plenary talk given by Dr. Carrie Norris and Work Group 5 on diversity, equity, and inclusion, health services research, and implementation science. I am your moderator today, Dr. Melissa Creary, and I am going to go over briefly our session goals, some reminders about the discussion, and then I will introduce the panel and we'll get going. So just to remind you, our session goals today are to describe some of the critical research priorities that were identified from the work group, to discuss avenues and challenges to accomplish them, to address any community questions and suggestions. So all sessions will be translated into Spanish. Please look for the translate button in the upper left area of your screen. Please also use the Q&A to submit questions and/or comments. We will try to get to as many questions as possible. If there are a lag in any questions, I will take moderator's privilege to ask some of my own in the meanwhile. NHF and the speakers here cannot offer any medical advice. Please consult with your bleeding disorders specialist if you have any personal medical questions. And you can find details on the development of the SOS and the scoring criteria in the resources section of the event website. Just to remind you all in terms of disclosures, everything spoken here today, particularly by Dr. Vanessa Byams, is not a representation of the Centers for Disease Control and Prevention. So let's go ahead and introduce our panel. We have a very esteemed panel, and we are delighted that you are here because it means that you engaged with all of the wonderful talks given by the people here to discuss with you all. We have Dr. Vanessa Byams, who's lead health scientist at the CDC in the Division of Blood Disorders. Dr. Tyler Buckner, who's Associate Professor in the Division of Hematology and is also the Director of the Hemophilia and Thrombosis Center Clinical Research Program at the University of Colorado School of Medicine. We have Dr. Carrie Norris, who gave a wonderful plenary discussion on the intersections of justice and public health and implementation science. And she's the Vice President of Health Equity, Diversity, and Inclusion at the National Hemophilia Foundation. We have our wonderful subject matter expert, Esmeralda Vasquez. Thank you for giving your remarks earlier today. And Dr. Emily Wheat, who's an assistant professor. Oh, I'm sorry, I should mention that Esmeralda also, while being a subject matter expert, is a person living with Glanzmann's thrombocythemia. I'm probably not saying that correctly, an ultra rare disorder. And she's also a pediatric occupational therapist and assistive technology provider for Stepping Stones Therapeutics. So she's wearing many hats, as we know consumers do, able to speak on many different things. And lastly, we've got Dr. Emily Wheat, who's an assistant professor, Department in Pediatrics, University of Colorado, and a psychologist for the Hemophilia and Thrombosis Center for the Children's Hospital Colorado Stroke Clinic. You may notice that Dr. Wheat and Dr. Buckner have similar, well, not anymore, but they're near each other in the same institution, so that's fun. So we will get started with positionality statements. So this is something that happened in work group 5 when we were discussing diversity, equity, and inclusion. I was asked to be a subject matter expert for that group. And I started the session with my own positionality. And that's just a statement about the kind of stakes that I have in the research that I'm involved in. And the statement is both personal and professional and sets the stage about my own perceptions of power and privilege. And I really, I think, helped to push the group to think about how, as researchers, we must be reflexive about our positions and transparent about the power and privilege, or lack thereof, we all bring to the research process. So I'll ask all of our presenters if they're comfortable to state their name again and speak a little to their positionality. And I'll start to model this. So I'm a science and technology studies scholar at a school of public health and value the methodologies of ethnography and oral history. Before I became that scholar, I was constantly playing the role of insider and outsider as someone living with sickle cell disease while also being part of the public health apparatus at CDC that was creating policy at different levels for the sickle cell disease community in my past life. As a professor invested in health equity and anti-racist teaching and research, I wanted to question everything, including disciplinary norms and assumptions, even if that meant pushing back on the processes of health equity. In my role as senior director at ATHN, American Thrombosis and Hemostasis Network, I am situated in the very data projects that aim to make lives better for people living with hemophilia and potentially sickle cell. And so I bring all of that positionality to that role too. I bring the positionality of being a Black woman, of being one of the first people to graduate with a PhD in my family, someone who's from the Caribbean. All of these things lends itself to the ways that I think and process through the way that I do research, the way that I engage with my research participants, the way I engage with research staff. All of these things construct how I think about my research and research portfolio. And so this is what I invited people to kind of think about in the DE&I group, and then we'll invite others to give their positionality statements now. I will let Vanessa start.
Thanks, Melissa. So in thinking about my intersecting identities, I think about my personal history and experiences that have shaped who I am. As a young girl, I was raised to conform to the majority cultural norms, to do what is expected and accepted, to be able to navigate white and male spaces so that I could be successful in my education and career. I don't say this as a critique to my parents, because they were preparing and protecting me. But I say that to say I've worked over time to try to bring my full authentic self and intersecting identities, perspectives, and values to my personal life and to my professional role at CDC. I am a Black woman and a public health professional and a wife and a scientist and a working mother and a manager and a Christian and a collaborator and I have many more pieces to my identity, as we all do. I believe we need to engage our multiple lenses to help us to try to understand others' perspectives and relate to others' identities. I think it's important that we all collectively bring our full selves to this transformational work of setting the research agenda for the inherited bleeding disorders community.
Thank you, Vanessa, for already beginning to model kind of bravery that I think being open and intentional around positionality calls for. I will ask Esmeralda to introduce herself and her positionality.
Hello, hola. My name is Esmeralda Vasquez, and I transcend 3 important identities that have been discussed over the past 3 days. I have an ultra rare bleeding disorder, Glanzmann's thrombasthenia, and I was diagnosed at the age of 1. I am a female, and I am an ethnic minority. My parents immigrated from Mexico, and I am a first-generation Mexican-American and a first-generation university graduate. I specifically requested to be part of Working Group 5, this group, because I am very familiar with some of the barriers that Latinx of low socioeconomic status experience while navigating the intricacies of our healthcare system. I know this from a personal experience, both as a consumer of healthcare services and also as a healthcare provider. I am an occupational therapist, and I work with individuals with profound disabilities. Being part of this group has helped me kind of see how much progress we've made throughout the past few years. But it has also kind of shed some light that we still have progress to go, which was kind of really nice, the conversations we were having throughout the weeks. I also feel that having someone from the inherited bleeding disorder community, such as myself, be a part of these conversations is a giant leap forward. I like the term subject matter expert because only we kind of know what our lived experience is. And it elevates us from just being passive consumers, passive patients, to being more active participants. So we can form this collaborative relationship with all those who are so interested in helping us just live a healthier and happier life. So I am very honored to be a part of this panel, and also just very humble to have this opportunity to either use my voice or just simply my presence. So thank you all.
Thank you so much, Esmeralda. Tyler.
Thanks, Melissa. So in my family, I play a number of roles. I'm a father of teenage boys, a husband, a son, a brother. To the outside world, I happen to also sit squarely in the middle of the non-marginalized. I am white, male, cisgender, heterosexual, Protestant. I recognize that many people are denied the opportunities that I've had during my lifetime to obtain education, training, and employment, and that many of those opportunities I have not personally earned, but rather have been given because of our society's assumptions based on these outward appearances. This approach to choosing who among us succeeds is inherently unfair. Despite seeing those disadvantages that were forced on others around me, I have taken advantage of my position in the system to become a hematologist and a researcher, roles that are personally rewarding and fulfilling for me. I do recognize that as a doctor and a researcher, I occupy a position of power relative to many of the people with whom I work, including patients, families, and other community members. I know that my perceived roles within the community, in addition to those societal roles that I've been given, impact the way that people interact with me or how they view my research proposals or how they respond to my questions. I'm very hopeful for a future where the views, input, and the worth of every member of our community, regardless of background, are recognized and celebrated so that others receive opportunities like I did. I am ready to listen and need your help to understand how I can best contribute to bring us closer to that future.
Thank you so much, Tyler. Carrie.
Thank you, Melissa. Goodness, there are so many communities that I belong to. Being raised in the South presented its own challenges in my early childhood, and being the youngest of 5 daughters definitely presented its own challenges with me creating my own identity and paving my own path, and being raised in a small suburb of Atlanta, and having various challenges around crime and drug-ridden neighborhoods, and also gangs at that time and things of that nature. And so a lot of my passion for health equity and a lot of my insight comes from my own lived experiences and being able to bring that to the table. So although accomplished TED Talk speaker, several degrees from well-recognized institutions, being able to work for some of the premier public health agencies, and also being able to be a staff member here at NHF and to hold a very prestigious position here as well, it still lends itself to me stepping outside of that privilege and remembering where I came from and my own lived experiences and challenges from communities that I've lived in and quote unquote survived. And also looking at various communities that I've worked with over my 20 years of experience of working in health equity and working throughout several communities in the United States and in the US territories, and seeing those challenges and hearing those lived experiences again, and going back to what I spoke about in regards to the qualitative lived experiences and the storytelling and listening to people tell you their history with the medical system and their history with access and treatment and care. Bringing all of that to the table puts me in a position to be an insider and an outsider as well, but also having the richness of having worked with communities and being a true and full partner with communities. And that's where the privilege and the position and the passion meet and come together. And that's where we're going to be able to see the needle move on health equity, I believe, is to continue to let the community lead us in the aspects where they are, as Esmeralda said, the subject matter experts, and we're hearing from them firsthand their lived experiences. And it continues to be this partnership of this give and take back and forth, and not take, and not include the community and not take anything back, but understanding where my past and my present have to come together in order for me to be the most effective health equity researcher, advocate, person on the ground, person at the forefront, wherever I'm sitting in the room, at the table, in the back, contributing however I'm needed, being able to bring those things together and acknowledging where I am in my current position and the power that that position has, and what I also owe to communities in order to make sure that their voices are heard and valued and included. Thank you.
Thank you, Carrie. Last but not least, Emily, I invite you to share your positionality.
Thanks, Melissa. So I identify as a white woman, and having grown up in a rural community with a father who was a rural physician, I saw firsthand what reliable access to medical care really means. I also am the youngest daughter amongst two older brothers as siblings, and so learned to be scrappy growing up. I apply that scrappiness in my position as a psychologist in an academic medical health setting. And that means I frequently observe opportunities for delivering behavioral health interventions in a setting where patients are primarily seeking medical care. Because of this, in addition to providing behavioral health care, I am often in the position of explaining the utility of this care to patients, providers, and staff. So I've gotten very familiar with justifying my own role and that of behavioral health in the medical domain. In addition to this, I am a full-time working mother of a toddler recently diagnosed with asthma. And while there's maybe a lot to unpack there, I would highlight that my role as a mom has given me the chance to learn firsthand what it's like to advocate within an increasingly complex medical care system for her own child with a chronic illness. I bring each of these aspects of my positionality with me across the various domains that I operate in.
Thank you so much, Emily. I appreciate each of you being so open about where you stand in terms of your positionality, and acknowledging how important it is to your viewpoint of how you come to research, and how you, whether you wanted to or not, lent those positionalities to this research process that NHF has kind of ushered forth for all of us. And I invite all of you that are listening to think about your positionality as you engage in your own research profiles, whether that means that you are being asked to join a study, or you are the principal investigator of that study, or you're a research assistant, to think about the ways in which all these positionalities that we all hold may intersect and lend themselves to creating particular dynamics, whether positive or negative, in the research enterprise. We will go over any questions that you may have had while listening to the amazing sessions that were brought forth by Carrie, Vanessa, and Tyler. We'll ask you to please add your questions into the Q&A portion of the interface. And while you're doing that, I'm going to start to ask some questions of my own. And I'll start with Carrie, particularly around her really powerful presentation about the intersections. You really do kind of set a path of how we can look at this really rich field of knowledge around implementation science, around some of the basics of public health for those of us that might not have been exposed to that before, and some of the notions of kind of, starter pack for social justice. In your role as Vice President of D&I for NHF, can you talk about, for you, what equity advocacy looks like?
So in my current role, what equity advocacy looks like is twofold. So there's internally with our team to make sure that things are equitable across the board in regards to protocols, processes, things of that nature, and to make sure that I'm in tune and working with those departments to answer any questions, to give and lend my expertise to anything that they're currently working on. If there are guidelines, recommendations, things of that nature that go out externally to our partners, to chapters, to HTCs, anything of that nature. And so what it looks like is being at the table with those whom we serve. And it's always this, I approach it with a servant leadership kind of attitude, where I'm listening, I'm being in tune, I'm making sure that I'm understanding what the community needs are first. And then in order for me to be an advocacy partner, fully collaborative in that process, is being able to say, okay, how are we going to set up our milestones for this advocacy work and what it looks like? And so that's kind of threefold. So it's the first step of looking at where the gaps are, whether it's policy, whether it's programs, whether it's services. And then the second step, moving from where the gaps are, is empowering people in the community to be able to advocate at their local level for their best health, for access, and then also for those wraparound services that help them to be their best selves and live lives that are thriving. And then that third part is making sure that whatever works, whether it's a promising practice or an evidence-based practice, to ensure that whatever we're putting forward works across all communities and looks at the uniqueness of those communities, and then making sure that we raise that up to the top. So it's not keeping it to ourselves, it's the dissemination. It's opportunities like this to present the work, to talk about the work groups where we're able to brainstorm and work together collaboratively to solve those issues, and then moving it forward. So from assessment all the way through dissemination, and throughout that process, including and empowering community members at each and every step.
That is perfect, a perfect segue for the next question, which is about mobilizing research. Work group 5, Emily, Esmeralda, Tyler, Vanessa, you guys had a very large breadth to cover in work group 5. It was about diversity, equity, inclusion. It was also about implementation science. It was also about health services research. And in each of those buckets, it was clear that things like access to care was a topic that could span, all 3 of those buckets. The other bucket, I think, that was very obvious was that in order to move the needle on any of these buckets, that we have to be able to mobilize research from the community level. And so I would ask the panel members what they think and what they, at the end of this process, how do we operationalize getting community at the table for creating and leading research priorities? And I'll start with Esmeralda, and then we'll go to Tyler, and then we'll see where we are on time.
I think I see this as a consumer and also as a healthcare professional. And I think one of the ways is to build that trust between the patient and the healthcare provider. Kind of like Tyler mentioned, kind of like evening out the power balance, building trust with the patient. And I also think it's when people try, for example, to work with Latino community, it's kind of nice when they meet us in our community, for example, like church settings, which we tend to congregate, and instead of having us come to a hospital setting that's very sterile and unfamiliar to us. So we want to engage more of the Latino community. Come to our environment and see what it's like. Take a firsthand look of some of the obstacles we encounter: transportation, access to like healthy foods, and grocery stores, like how far we have to commute to access a hemophilia treatment center, because then you can kind of really see some of the struggles that we encounter. So that's just something that I kind of learned through this process. I lived it as a patient, and then me working with Latino community, that's what I see. So I can understand when patients come late to my appointment and telling me like the bus arrived 30 minutes late. So I'm 30 minutes late to my appointment. So I think like I said, just come to our communities, and you'll kind of really see and understand and get to know us a little bit better and improve those relationships and that trust.
Thank you so much, Esmeralda. Trust really is the key to bringing communities to the table to engage in research and in any kind of research. Tyler, what are your thoughts?
I think something that we talked about again and again in all three of our kind of sections was education, and not just of any particular profession or group, but of all of us. I think that cooperative, shared, broad-based educational efforts are needed, particularly because these areas are relatively unfamiliar in the research world for bleeding disorders specifically. I think that presents us as a community with an opportunity to engage in that kind of learning and journey together with all the different groups within our community, whether it's patients and families and providers and other partners, so that we can essentially all be on the same page, so that we know that what are the issues that are most pertinent and most urgent to address, and how do we go about addressing those using established rigorous research methods. What types of approaches to research studies are needed for answering these types of questions, because we found that it's challenging. It's challenging to even word the questions sometimes in a way that we're used to. And so I think that education is important, and again gives us a chance to partner with folks that we aren't perhaps used to partnering with in those kinds of efforts. So I think that's where I would start, is with that kind of engagement.
Thank you, Tyler. I'm going to let Vanessa and Emily both speak to the question as well. We have some questions coming in, so then we'll pivot towards some audience questions as well.
Yeah, thank you, Melissa. I would also say, to piggyback on Tyler's point, is along with that education, I think sort of the reflexive exercises that you led us through, Melissa, also, and having making sure, in addition to training and resources, that there's that expert sort of training and guidance related to being reflexive about your position, thinking, asking reflexive questions, to sort of understand from a different perspective. And I think the other point that I wanted to make was, as far as engaging communities, something else that came up in our conversations was just to make sure that we are, providing opportunities for community members to co-create with providers and researchers, and they are at the table giving that input, at the beginning of the process when it comes to development, in the midst of the research process, throughout the whole cycle. And, I think many of us can admit that, we don't always do that well, even when we have close collaborations with NHF and HFA and other patient organizations, that we need to be more intentional about having that perspective at the table, and also that it's authentic, that when we seek community perspectives, that we're not thinking, oh, we need to get one person from this certain racial or minority group. We need one woman here we want to be authentic in making sure that whatever the questions are, that we are reaching out and partnering in a way that's, again, very intentional.
Thank you, Vanessa. I think also what you're getting at is that we don't want it to be performative. We want to go beyond the notion of just representation for representation's sake. And how do we properly engage community? Again, that begins with trust to make sure those authentic relationships are built so that when they come to the table, when these communities come to the table, we don't have to worry about, well, this person's not going to say anything and we don't need them to say anything because they're just representing a particular group, a number, what have you. So thank you so much for raising that point, Emily. And then I'm going to move on to a question submitted by Noelle Simpson.
Thanks, Melissa. As we've all talked about, that engagement with the community is so important. And one methodology that we discussed in our working group was the use of qualitative studies. So instead of just crunching numbers and using models or measures that have already been developed on a majority population, perhaps going back to the basics and back to the community members that we really want to make sure to represent, and doing those open-ended or structured interviews to really rebuild things from the ground up. And I think, as just kind of looping back to Esmeralda's point, building that trust to be able to do that science well is really important.
Thank you so much. Okay, so we're going to pivot a little bit towards accountability. So I personally really appreciated the emphasis of implementation research over clinical research in our conversations in the work group, because it prioritizes things like organizational strategy and what kind of changes can happen on the clinical unit or on the organizational unit, right? And often this is fraught because of leadership priorities or the capacity of individuals who might create change. And so that really links well with this next question, which is, what commitments or plans of action do the members of this working group and NHF have to keep healthcare teams, including HTCs, chapters, sponsors, pharma, researchers, and thought leaders, accountable in their anti-racist work? This is a very specific question and a very specific lens of diversity, equity, and inclusion. We know in the Bleeding communities that this also involves rural communities and women and with bleeding disorders, right? That intersectionality piece. But this question is specifically about racial and ethnic minoritized communities. How does NHF and this work group plan to hold this broad span of the network accountable in their anti-racist work? Is it possible? I'll put Carrie on the spot as the NHF representative of this panel.
Oh, that's perfectly fine. So specifically, we have guidelines and we also have recommendations for HTCs, and the current structure of our HTCs are those that have core teams. And so in the core team, you have this multidisciplinary team that covers everything. So it's the hematologist, it's the healthcare provider, it's the nurse, it's the medical social worker, it's also the patient liaison, and also the mental health person as well on team. And so all of these facets then cover the gamut of what each individual patient consumer needs. Our job in the guidelines is to make sure that those guidelines are very specific about what we want to see in regards to cultural sensitivity, linguistically and culturally appropriate care, education at the HTC, and things along those lines of that nature, of accountability, of professional development as well, in regards to those core team members and expectations around that and recommendations and guidelines around that. And so that's how NHF gives their guidelines and recommendations for those things, and also practices a level of accountability by updating those guidelines to make sure that we are walking what we're talking. So it's not just we're putting out these things, we have this figurehead who's doing this, but it's in the recommendations and guidelines for what HTCs should be doing in order to address all community members, and also to be able to make sure that in those linguistically appropriate and culturally aware and culturally sensitive and other areas, that they're getting these trainings, and that I'm working right now with team members to create trainings for those persons that will then enhance their already really great skill set, but enhance their skill set with the tools that they need to make sure that we are holding them accountable along those particular lines as much as we can hold them accountable, so to speak.
Thank you, Carrie. Okay, I'm going to let Vanessa speak, and then Tyler, and then Esmeralda.
Thanks. Yeah, just to again add to that, specifically for the HTC context, you have to think about also the local context of, you know, what is the organizational culture there? Is there a culture that, you know, supports these values and emphasizes these values? Are there any policies, just in terms of, again, another layer of accountability, are there policies to which employees need to be accountable to help reinforce that? Is there leadership support that uplifts those values, whether it's, you know, formal leaders or informal leaders? You know, what's the water cooler talk? Is that in alignment with the purported values, or are those, is there, you know, a disconnect? And I'm not, you know, this goes for HTCs, this goes for any organization, and we all, you know, work and exist within organizations which, you know, involve people and structures and processes. So, you know, and we should also be mindful that, you know, there could be a certain culture or way of doing things within an HTC, but that HTC is also part of a larger institution, and that larger academic medical institution might be part of a larger healthcare system, and they have their own culture and values and potentially policies. So, you know, we definitely, and that's part of what our working group, you know, talked about, is we definitely, you know, have our work cut out to be able to, you know, assess, you know, what is going on within a healthcare organization, so we can see what's happening, and then we'll know how to address it.
And I'll kind of continue to, that was nicely timed, Vanessa, with what I was thinking, is that progress from the macro national level to the local level, and to what I see as something that's all of our responsibilities, which is our own internal accountability, also has to be part of this. It can't just be a policy that NHF carefully crafts and then and disseminates out to the participating groups that they interact with, or work at one HTC within one institution. It also has to come along with our own assessments of ourselves. Just like we started with positionality, we have to be aware of our own biases and work against them, particularly when they impact others around us, and especially when they impact the people that we're charged with caring for, caring for each other. And that's hard to do. We learned during our work that it's uncomfortable to even talk about or to acknowledge that those things exist. I feel like we went through a bit of a phase where we had to get comfortable saying that, yes, there is racism, and we have to not be afraid to point that out and call it what it is, and work against it actively. Now, how do you measure that and prove that you're walking the walk, I guess, or the walking the talk? I don't know. I think it's very difficult at the individual level to demonstrate that, as well as at the local level. How do you show what you're doing is making a difference? But I don't think that means that we can't or that we shouldn't. And so part of our working group's realization toward the end was that we don't want this work to stop. We don't want this to be just the state of the science. We just had this cool group that came together and talked for 6 months, and then we go our separate ways. But that to really try to drive that forward and make this more of a routine part of what our community, as researchers, as care providers, as patients, as consumers, as family members, what we think about when we are working toward the greater good, that this is all has to be part of it, and that internal struggle is necessary.
Thank you, Tyler. And I'm coming to you, Esmeralda. I want to just put out there something that Kamara Jones, who's an internationally renowned scholar on racism and health, she is always asking, how is racism operating here, to assume that it is, right? And so I do think that that's something that I was very clearly brought into the discussions of our group in work group 5, is that no longer can we say, is this a thing that's happening, but how is it operating, particularly in the bleeding disorders community? Esmeralda, before I pivot to you, I know that you participated in a session at the recent Blood Disorders Conference on Patientcentricity. And I wonder if you could talk about how the work of this working group intersects with notions of being patient-centric in your response to this broad question of accountability and anti-racist work.
Well, I just want to kind of make one comment when we're talking about the guidelines. So I attend an HTC center. I'm from Chicago. I live in Chicago, and Chicago is very diverse. And I see the sincere cultural humility that's practiced in that HTC center. And I didn't know the NHF had guidelines to kind of guide this, which is really nice to hear. But my concern is what happens to community hospitals that don't have HTC centers, where I know like a lot of people of color attend? Is there like a collaboration with those hematologists and those, because that's the reason I got into the HTC center that I attended. I was really not satisfied with the care that I was receiving at the community hospital that I attended. So I started doing my own research, and I came across HTC centers that I didn't even know existed. So I wasn't sure if there's guidelines to kind of guide those healthcare providers, and also because I know there's a lot of diversity in those community hospitals, to kind of get the engagement of the community involved. So that was just kind of a question that I had for Carrie. And then I guess, do you want me, Melissa, to answer your question, or just, okay. So when I attended that other panel, trying to kind of come up with how to operationalize, I guess, define patient centricity, it was, to me, it is what it is, what's happening right now. And I actually developed this conceptual model to kind of explain to the audience what it means to me. And it kind of means the conversation that we're having now, engaging the community in a very nice, collaborative, respectful way. When thinking about a patient, understanding that the patient is part of a family unit, is part of a community, and is part of a much larger system that I can't even wrap my head around, like how are these guidelines and hospital policies work. But when I think of patient centricity, is kind of in these conversations, somehow getting the community involved. And I think like panels, and obviously like Zoom is accessing people throughout the US, which is very, very nice and easy. So that's kind of what it means to me, like patient centricity and this collaborative effort. So did like two little like diagrams, like a back and forth relationship, advocacy, research, and the clinical care aspect. Because I feel like as a consumer of healthcare services, part of the community, like I feel like we have a role in each of those areas.
Thank you, Esmeralda. Emily, I see your hand, but for timing, I'm going to move on to the next question. The next comment and question is from Donna D. McKelly, and she says, to all thought-provoking presentations, it would be great for the panel to discuss their vision for how the HTC network might evolve to actually deliver this community-based transformational healthcare that Dr. Norris discussed, and better meet NHF's equity, inclusion, and social justice goals. So this is about vision for how the HTC network might evolve. I'm gonna, again, take moderator's privilege to say that, there's a whole methodology called community-based participatory research. I'm seeing nodding heads, and that is one of the ways that we can transform healthcare vis-a-vis the auspices of research by being intentional. And I think Dr. Norris said this at the very beginning, or maybe it was Vanessa, or maybe it was all of us, because we're all in the same choir. We're all preaching to the choir on this panel. But it's about the very beginning, finding out what the community needs and letting them dictate everything. Understanding that this is going to potentially muddy up timelines, muddy up how budgets go, muddy up everything you think about the research process, which is already muddied. But I'm going to pose this back to the panel, a vision for how the HTC network might evolve to deliver community-based transformational healthcare. And because this is a research group, we know that research can help transform healthcare and better meet NHF's equity, inclusion, and social justice goals. And if Emily, you have something to say towards that question, I can bring you in here. Otherwise, I'm going to pivot again to the NHF rep, since one of the questions is specifically about meeting their goals.
Thank you, Melissa. I would say in regards to the research, many of these things can't be done without funding, without systemic support. So, and that kind of comes back to the point I wanted to make about the last question with accountability, that we really, our HTCs, our centers, and our communities really need funding in place to support the research and the program development that needs to happen to implement, to make some of these changes, and then to show their effectiveness. And so I think that really applies, to both scenarios.
Thank you, Emily. Carrie.
So what I would say is first and foremost, I want to say there are HTCs that are doing great jobs. So we're not saying that they aren't on the pathway or working towards this already. So that's the first thing I want to say. The next thing I'd like to say is, in order to get there, again, this patient-centric model, and also layered with addressing any type of unconscious bias or implicit bias practiced by anyone within the healthcare, within that particular setting where they're receiving care and services and treatment, in addition to aligning yourself with everything that each patient and consumer needs. So we're not saying that HTC should take care of people's rent or people's, social support networks or any of those things, but aligning the HTC services with other organizations to make sure that you're filling the gap and you're addressing the whole patient will get us on this pathway. Again, it's the community-based participatory research where you have the community at the center and you're being patient-centric with access and treatment, and then addressing those that have particular challenges with transportation or telehealth or what have you, given our current situation throughout the country, in addition to looking at specifically how you're able to align yourself with other orgs to meet the additional needs, and you're addressing the entire patient. So if there's a particular family that has multiple members with multiple bleeding disorders with various types of treatment, then you're thinking about the funding for that. You're thinking about their competing interests. You're thinking about transportation. You're thinking about health insurance. You're thinking about all of the challenges that come with that. You know, if they're employed, if COVID has affected their employment rate. So all of these things. So then you have well received and well recognized relationships with other community-based organizations so that you're meeting the entire need. That's where the transformation comes in, where it's not just you come in, you get this service, you know, we get reimbursed for providing you this service or this treatment or what have you, but we're looking at you as a whole patient. How's your mental health? How are things going? If you're stressed, it's going to affect your health outcomes. So what's stressing you? Oh, I can't pay a particular bill, or I'm having trouble meeting something, or, you know, my husband or my partner lost their job. Whatever the situation is, we have someone immediately that we can connect you with. Is it United Way? Is it another agency that's in the immediate vicinity that can supplement and support these services? And so when we talk about this transformational model, and we talk about this patient-centric model, then we are truly addressing everything that touches the patient. We're not putting it on the HTCs to be the panacea for everything and to cure everything, but to definitely be the connector in the picture where we are addressing everything that potentially touches the patient, where we can definitely refer them out and have community liaisons that can help them with other areas that then ultimately affect their mental and physical health.
Thank you. I see Len has his hand raised. I'm gonna let Len address the question, and then Vanessa, I'll ask you to come in after Len.
Yeah, so first, Melissa, congratulations on an outstanding panel. Really well done. You know, as Carrie said, NHF is not a social organization. We're not designed, we don't have the expertise, but we are going to ensure that we're going to take care of people in the community. And as Carrie said, to be able to be the connector and to be able to support those individuals, as we did during you know, the early days of COVID, when there was COVID relief provided through the chapters. I think it's really important that we recognize the place that we have in terms of fulfilling the mission that NHF has adopted to ensure the health and well-being of people and families with inheritable blood disorders. And I think it's important that we recognize that there are social issues that need to be dealt with. And although we may not be experts in these areas, we're going to find those experts and connect with them. So I think Carrie's spot on in how NHF needs to approach this by collaborating with others.
Thanks, Len. Vanessa.
Yes, no, I agree. And Carrie definitely addressed that in a fantastic way. And I would just, and I'm probably queuing it up to Tyler or Emily, but one of the issues that came up frequently when I think about what transformational sort of changes within the HTC, there was some discussion about just the important role of behavioral and mental health and pain management, and maybe how that could be further emphasized and integrated. And so Tyler or Emily can speak to that better than me.
Again, we're on the same wavelength, Vanessa. I mean, that's those. So these are exactly the points that I wanted to make. You know, when thinking about a vision of how do we transform the HTC model, which already has so many advantages that we enjoy, how do we make it even better? And in my mind, I think about how do we shift the balance of costs and benefits for our patients so that it's more weighted toward the benefits side. You know, what are the costs of being cared for by the HTC? What biases are present that in our clinics and institutions that we need to address and remove to reduce that cost of simply showing up? What is the cost of travel time? How do we go to where patients are so that they don't have to worry as much about how they're going to get here. How do we address insurance issues, address medication cost issues? How do we reduce those costs of being part of or being a part of this community? And then on the benefit side, I think that offering and taking on, more of these issues that are important to our patients and that have been identified time and again, that you mentioned, Vanessa, pain management for so many people who are affected by chronic pain. Why is that not part of what we do? And that's part of life for so many of the people we take care of. Mental health is exceedingly important, and addressing well-being and issues related to wellness and healthy living should be part of what we do. As pointed out in other State of Science sessions yesterday, there are problems, medical problems, that are increasingly being recognized as very overrepresented in a lot of our patient groups, like hypertension. I've personally always been resistant as a hematologist to managing somebody's high blood pressure, because I feel like I don't know how to do it as well as, say, a cardiologist or a nephrologist or an internist or a family medicine doctor. But perhaps we need to change that and make it so that, these pressing medical issues could be addressed even within a very subspecialized place like the hemophilia treatment center. So I think shifting that cost benefit balance is there are multiple ways to do that, and it's going to be a little different at each center. But I think that opportunity exists.
Thanks, Tyler. I'm gonna pivot to Emily, and then I have a provocative question for everyone.
Thanks, Melissa. Yeah, I feel like it's important just to note that we really do have some opportunities for the behavioral health realm from a research perspective for our bleeding disorder patient populations. We've got some amazing medical treatments out there that will give us the opportunity to, kind of shift our focus a little bit to things like, Tyler mentioned concerns related to pain or depression, anxiety, trauma, and chronic stress. And in the world of hemophilia, there are only 7 psychological interventions that have been created from 1975 until 2015. And if you compare that to some of our partnering illness groups, so oncology, there are 19 randomized controlled trials published in between 2006 to 2007 alone. And of those, 17 were pediatric specific interventions. And then if you look at the quality of those psychological interventions in hemophilia, they're rated really low, so low to very low, using the GRADE framework, a framework that looks at quality of evidence. And then, when it comes to assessing behavioral health, we're often not using gold standard measures. We rely on patient reports of the presence or absence of anxiety or depression, or measures that aren't really initially designed to even assess psychological concerns, or maybe even omit this topic completely. And I would say we don't really know how psychological supports could optimize things like patient adherence to treatment. And with all the cool things that we're doing with gene therapy, we really haven't, again, to my knowledge, conducted research on the cognitive, emotional, and social impacts of these types of treatments. And I think that's really important. So we've got some opportunities here in the research realm for the behavioral health side of things to really do better.
Thanks, Emily. I remember giving a keynote about justice and like algorithmic something another. And afterwards, someone asked me, "Were you meaning to be so provocative?" And I was like, "What? I was just asking some questions." All that to lead us into this next question around okay, so we're being intentional about transforming the system, right? Because this is a systemic process, a systemic problem. We are addressing racism. We are being intentional about having health equity programs in the HTCs. We are traveling to where the communities are, literally. We are establishing CBPR. We are understanding that timelines are being skewed, and we have to actually add 2 more years to this thing in order to get the outcome that we thought we were going to get. And so the question for the group is, do you anticipate any pushback from anyone in the greater inherited bleeding disorders community? As we have seen recently, entire states have denied teaching some of these types of ideas. I'm just going to say, put it out there, critical race theory, right, is what was being talked about here. And critical race theory definitely has a hand in anti-racist principles, and particularly around anti-racist research methodologies. And so how will that be addressed? I don't think we can necessarily speak to how individual HTCs, how that might be addressed in individual HTCs, but we could imagine, right, that there could be some pushback if we were to begin to center the margins, if you will, begin to center things like anti-racism. And to be clear, to be anti-racist is to lift everybody up in this boat, right? It's not just about race necessarily. It's about this reflexivity that has a hand in transforming the way we think about all kinds of identities. So that being said, what happens if there's pushback?
I'll dive in. I think we have to assume that there will be pushback in any situation, and be prepared to have a discussion, and even to encourage a discussion. And that, I think, is the challenge, because often there is lack of willingness to engage in an actual conversation, at least in my kind of view of how things have gone with these issues that you brought up, that have, you know, become, for some reason, become you know, real touch points for whatever group. Why is critical race theory, which has existed for a long time, suddenly being talked about and mischaracterized and used as a you know, a battering ram in a lot of cases? And so I think being prepared to open up those discussions when we do get pushback, because I think it would come in many forms, even from a simple standpoint of having seen so many patients in my own clinics with pain, and knowing that that's an issue, you know, even in the pediatric clinic for some people, and yet still getting pushback after years of giving talks about pain, about, well, this either isn't our problem because we're hematologists, or it doesn't actually exist in kids, or it's something that it's somebody else's issue to address. Learning how to anticipate those concerns and arguments, which are really discussion starters. And so I think that, in my mind, we're all amongst friends. As you said, this is preaching to the choir. So it's easy to have a panel discussion like this about these kinds of things on Zoom. And yet we have to enter into it with a determination to not get discouraged by, you know, whatever challenges we face, whether it's not finding funding for our qualitative study, or whether it's someone being upset by the ways that we change our clinics to be more welcoming of others. I think all those things are certainly possible and should be anticipated, and another aspect of what we have to figure out together.
And the pushback can come in a lot of different ways, right? The pushback can be as in your face as, I'm going to deny funding. But the pushback could be something that I witnessed where in work group 5, we had 3 of these topics. We had DE&I, we had implementation science, we had health services research. I saw people attend health services research and implementation science, but not attend, DE&I. So it may be something as subtle as I'm going to just retract from having the conversation completely, or I'm going to find something else to do. So, it looks a lot of different ways to a lot of different people. And they're all problematic in different kinds of ways, because erasure can be just as problematic, or just complete denial of a situation can be just as problematic as someone who wants to be really forceful and voiceful, full of voice about it. I saw Emily's hand and I see Vanessa's hand. I also don't want to leave Carrie Norris out of this conversation. So I will pivot to Emily and then Vanessa. We'll see if Carrie has something to say. And then there's one more question that I think we can tackle in the last 20 minutes or so.
Thanks, Melissa. I just wanted to echo Tyler in saying that we probably should anticipate that this will come up, and also to loop back around to our working group, really liking each other a lot, and maybe thinking that we could be a resource to help offer ourselves as a resource for those who are coming up against this opposition in the future. Now, I see some of our work group team members, not just here as panelists, but also in the chat. So you may not be excited about being volunteered for this opportunity. However, I think we could really be a great resource for our community and kind of HTC members out there.
Absolutely.
Yeah, thanks. Oh, sorry.
No, I was just going to say, I'm looking forward to what happens in the aftermath of the SOS. Go ahead, Vanessa.
Yeah, absolutely. I definitely agree with Emily. And I would also say something that came up in our group, and I concur, there definitely will be pushback because, the reasons that you mentioned, Melissa, potentially for sure, but then also, this is hard. I think about some of those sessions that we had, and we were stumped. and Melissa really, tried to push us to think and consider these issues and to really have these conversations. So I think it being something difficult can make people be at arm's length. And I think the fact of that they are so large and systemic, we're not going to solve this year. NHF is not going to solve it. None of us are going to be able to solve it in a year, 2 years, 5 years. It's going to be something we all have to be committed to take incremental steps to build on a foundation of everything that it's going to take to really be inclusive as a community. So I just wanted to bring up that point that we're not minimizing that this is hard, but I know all of us and all of the participants also have done hard things. And so I think if we're committed, and as Emily said, try to be resources for each other, a learning community within the IBD community, because I also remember work group members, like people want and need like tangible resources. How do I do this? What can I take back to my site so that I can really do this work? And people do want to do the work is the other thing that we should also keep in mind. So we just want to, make sure that we come together as a larger community to give people those resources and to help each other.
Yeah. Thank you, Vanessa. Okay, Carrie, you get the last word before we move on to the final question, if you have a last word.
Thank you. I have to echo Vanessa's sentiments. It's about putting the resources out there. So it's determining what types of resources we're going to create. There are the on-demand trainings that can be done. There are fact sheets. There are also resource guides, things of that nature, in addition to providing technical assistance to those organizations that are open and that are willing. And so for all things, we know that we have early adopters, we have late adopters, and then we have those who are just completely resistant. You work with who wants to work with you and who's willing to do the work first, and then you slowly integrate your way into the other realms by finding, again, kind of what I've done in this space, which is coming together around similarities and then teaching others to respect those differences, right? And so we have to find a way to at least get those people who are a bit hesitant or resistant to the table, because we learn from them as well. And in effort of getting them to the table, it at least shows that they're willing to have the conversation. So tell us why you have the opposition, and then we move it forward to talking to what we can do, what is feasible, what is comfortable. And I think the first thing we have to let people know is we're not trying to change you, the individual. We're trying to change the situation for the actual patient and consumers and for the communities. However, you will have to do some self-awareness and some self-regulation in order to stay in this space. And so what I would say is we have to continue to do this collaborative type of work that we're doing right now, and to not stop here and to keep going forward. And remember, difficult takes a day, impossible takes a week. We can do it.
Thank you so much. And I want to add this and one more comment before we move into the space of wrapping up, that this is about a continual spectrum of unlearning and re-navigating the world as you see it. So re-navigating how you think the HTC should work, re-navigating who you think your patient population is, re-navigating how the biases may or may not operate in yourself, in greater society, and then how that translates into the medical system that we all have to navigate through. I would concur with Vanessa that this is hard work. And the DE&I keeps showing up, even though we have those other two buckets that this group discussed, health services research and implementation science. And there's a reason why this keeps rising to the top. And it has, it really does connect all of the ways and all of the topics that this group has tried to tackle, and I think has tackled really gracefully. You can't get to health services research and implementation science without community at the table. So it's almost like 101, we have to like crack that nut first. So I want to make sure that I recognize that Bob Robinson has something in the chat. We won't be able to get to his question, but he does offer this. Other healthcare systems have looked at coordinating with systems already in place to address health equity for improvement. We are not rebuilding the wheel here, is what Bob Robinson is saying. Does the panel think there's a possibility for the bleeding disorders community to partner with our chapters, which are already established and know the community? So what Bob is saying is that get to know the people that are already on the ground, that have already done the work, that can offer the lessons so that we don't have to learn those lessons from the very beginning. Okay, there's 15 minutes remaining, and this is what we're going to wrap up with. What are the critical research questions in this space? Again, thinking about not only DE&I, but health services research and implementation science. Is there research that needs to be done? I would say yes. How do we uncover our unknown unknowns? Those are some big questions, but that's how we're going to end it on this wonderful Tuesday afternoon. What are the critical research questions in this space? I'm going to leave that with Tyler and Vanessa as the work group leads. Is there research that needs to be done? I'm going to put that in the hands of Esmeralda. How do we uncover our unknown unknowns? I'm just going to put that out there in the atmosphere. Whoever wants to answer that can answer that. But first, Tyler and Vanessa about critical research questions that rose to the top.
I'll start just so that I don't lose my thoughts that I have in my head. So I think just because there are questions that could be answered or start to be answered now that we can integrate into the research as it's being developed today is this issue of hybrid research designs that we see comes from implementation science. And really what those kinds of questions are asking is, how do we ensure that we know enough about how an intervention works in the real world, in the clinic, with real people who are not part of a clinical trial, that we can bridge the gap between the wonderful scientific evidence that is being generated by our researchers and practice in our clinics. And so learning how, as we design clinical trials, as we design observational studies, as we design other interventions, how to understand what makes those interventions tick, what keeps us, what are the barriers, what are the facilitators to making those things work in the clinic. And that in particular needs to focus on issues related to equity and inclusion, and how do we know that our interventions can be brought effectively and efficiently and fairly to all of our patients and in all the communities with whom we work. And so it's not a specific question, but it is a shift in our practice and how we design studies. You know, we've talked a lot about not limiting ourselves to the annualized bleed rate as a clinical trial outcome. We need to incorporate these other outcomes. How long does it take to talk to somebody about this? How much does it cost? How does it get infused, et cetera? All these practical issues can be measured and can help aid in getting these practices out to all of our patients.
Thanks, Tyler. Vanessa?
Yeah, I would say, and we have dozens of questions. So we have many, many questions that we can and we will put forward. But I'm thinking about discussions where in the working group we talked about, and this is also tying into the unknown, how do we uncover our unknowns is also just making sure, especially thinking about the various communities and identities that we have in the bleeding disorders population, that we make sure they are represented in what we do. And we've talked a little bit about sort of that qualitative aspect of it, making sure we're getting their stories. But I think also in the quantitative data, there are some places that we are capturing certain groups, women, girls, persons with the potential to menstruate. I meant to sort of link back to that earlier, but I forgot. There were excellent talks about this yesterday, and that population and how they've experienced sexism and how that factors into their care and treatment. Definitely don't want to lose sight of that. But there are groups that we're not capturing information that well so that they can be represented, that their voices are represented. So in terms of, different gender identities, sexuality, even sort of more information about, disability status and challenges in that area. There's, language, culture. I mean, there's a very long list, and there's some things that we don't know. So, that's what's coming to mind when I think about the unknowns, and we're going to have to, integrate that into our various, data collection, or, maybe even find sort of other ways. Are there other existing data that maybe we're not aware of that we can sort of get more information about some of those subpopulations? But I think we're going to have to, more fully integrate it. I know Athens has integrated gender identity more fully, and that's something, thinking about community count, CDC surveillance, that's something that we would like to be able to integrate those elements as well, so that we make sure that we have that health information and can understand the health status of other populations who may be having challenges with their care and need additional attention.
Yeah, thank you. Okay, Esmeralda, is there research that needs to be done?
Yes. I know we didn't talk about this a lot. Well, actually, I don't think we talked about it at all in our working groups. But a part of when I think of diversity, equity, and inclusion, I also think about age. And I feel like a 70-year-old with Glanzmann's thrombasthenia deserves the same amount of care and comprehensive treatment as a 7-year-old with Glanzmann's thrombasthenia. As I'm entering my middle-aged years, it worries me that is insurance coverage going to limit my access to a healthcare treatment center, hemophilia treatment center? The reason I'm being able to receive services there is because I had to switch from an HMO to a PPO. And I know that's not available for everybody. So in that way, I'm kind of a little privileged that I have access to pay a little bit more for my insurance. And it gets me thinking, what's going to happen when I no longer have private insurance and I have to rely on Medicare? Are they going to pay for my Novo 7? Or things like, if I have to end up in a skilled nursing facility, are they going to accept me because I potentially may need an infusion or specialized care? So all those things like started running through my head as I was going through the working groups and listening to the conversations on Sunday. And I know I'm only like 42 and 60 something is still very far away, but I'm already starting to really think. And I really like upload my healthcare savings account, like planning financially, like how's my future going to look like as a 70-year-old or potentially 80-year-old with a ultra rare bleeding disorder?
Yeah, that's such a great point. I know with conversations with other people that a lot of the HTCs are having conversations about, are you going to get covered? Where's the best place before you change jobs? Let's discuss your healthcare coverage that you may have with this job versus the other job. Folks with chronic disease have to think about this all of the time and to do this kind of planning out. So thank you for that. And thinking about, how does that wrap into research questions, I think is a really good point for us to hear. So there are about 6 minutes left. I'm gonna leave 5 of that to how do we uncover our unknown unknowns. And Vanessa spoke to it a little bit, but if anyone else wants to add some final thoughts to these, how do we delve into the unknowns? I would say that the more conversations you have and the more opportunities that you have to bring people to the table who have different ideas than you, that's how we get to uncover a little bit of the unknown unknowns, right? And which has been pretty much the crux of this conversation, is how do we thoughtfully engage with making sure that all kinds of people are at this table and not just for being at the table's sake. Carrie, I yield the floor.
Thank you. So with the unknown unknowns, a part of that is easy because we already have members of the community that know the unknown unknowns. And so through these, through their, again, lived experiences of telling us some of the challenges that we don't already immediately see on paper that kind of bubble up through their experience, similar to what Esmeralda just explained, is a concern for her. Then when you have those conversations, then now it's at the top of our list. It's on our radar. We know that. And so I've been having these conversations with Lynn in regards to being able to do some photo voice and some in-person interviews with people from the community, just everywhere, because I believe that that's going to give us our first stepping stone to the unknown unknowns. Because think about it, everyone in care at least knows someone with the same condition that's not in care for whatever reason, be it monetary, be it a transportation issue, just access across the gamut of when we look at the spectrum of access issues. And in that, they can connect us then with those persons and say, Mary's my longtime friend. We started out bringing our kids to the HTCs together, and she dropped out of care because of, job issue or insurance issue. They still have that connection into the community So when we look at those 6 degrees of separation and start talking to community members outside of surveys and getting these stories and lived examples, then I think we're going to uncover a lot of the unknown unknowns and then the data that's missing. So this is something that we know missing data is a form of oppression as well. A lot of times we don't include or we throw out the data where we don't have, a large enough set of information or numbers from certain community members. Or you'll have conversations and say, oh, we don't have people from that community that are part of the bleeding disorders community. Well, how do you know that? Well, they're not showing up in the numbers. Did you talk to them? Did you approach them? Do you know this for sure? Or are we just guessing? And so again, trust building those relationships where then you can find out and you're not just guessing because the numbers are missing or aren't there. And so I think that delving into the data, looking at what we aren't asking in specific surveys and questions, looking at who's missing, but we know that they're a part of the community, but it's not showing up in the numbers is a way of doing it. And then again, these opportunities for the qualitative lived experiences through photo voice and also through in-person interviews will give us a lot of insight into the unknowns.
Vanessa, I'm sorry, I'm going to have to leave it here, but I do want to end with this, someone who is thinking about these things with health equity and anti-racism, who's in a place like Athens that's so data-centric. We're thinking about all the data that we have access to surveillance-wise are in the Athens data set. And we're, I know with what's been going on with conversations in the community about this data that's coming out now, we're asking the questions, who isn't being counted? Is there representation? Is there proper representation here? How do we get at these numbers? How do we ensure that the enrollment looks the way we think it looks? How do we address data equity issues? How do we make sure that if we know that data is used for action, and action propels this whole thing, it propels research, it propels policy, we have to make sure that the data at hand is the best data we can have our hands on. And that includes a robust sample of everyone. And it involves quantitative and it involves qualitative, right? Those things have definitely risen to the top, I think, for our conversations today, and hopefully will continue beyond. It is 2:29. I'm going to say thank you so much for all of you and your insightful comments. Thank you for being here and putting all of the time in, the work group leaders and the organization that you put forth for work group 5, the panel members, the dedication over 6 months. And NHF, I applaud you for this process from beginning to end, from the listening sessions to where we are today. It's such a feat, and we're all going to be looking to hear what's next. So congratulations, and we are on board, at least in these squares, and I'm sure many of those in the audience as well.
Thank you.
Thank you for a terrific panel discussion.
You guys are amazing.
Thank you.
On to the next thing.